On behalf of the Brazilian Society of Pediatric Neurosurgery, I would like to thank you all the participants, delegates, and our sponsor to be here in this
on behalf of the Brazilian Society of Pediatric Neurosurgery.
My topic today
I would
is
like
about
to thank you
all the
third ventriculostomy, a long-term results in the pediatric population.
To be here in this
I
on
have
behalf
no
of the
conflict
Brazilian
of
Society
interest to
of
declare.
Pediatric Neurosurgery.
My topic
today
I would
is
like to
about
highlight
all
third
the
ventriculostomy,
ETV
a long-term
delegates and our
results
sponsor.
in the pediatric
In the
population.
third
To be
ventriculostomy,
here
management
I have
on
no
behalf of
conflict
the
of interest
have
to
reported
declare. My
results
topic
today
I would
is
like
about
to highlight
all
third
the range
ventriculostomy,
from
less
less
than
than
30
up to
to
100% of success. The medical literature also has extensive today
I would
that
like to highlight
third
ventriculostomy
from
less
less
than
than
30
30
age
in the
percent
of
of
success.
in the success
The medical
rate
literature
of endoscopic
also
procedure.
has extensive
ETV
data
highlight
is also controversial because of high failure rate and technical difficulties. The long-term efficacy of ETV is often under debate, since most studies have reported a rather short follow-up period. In summary, there are three major factors that play a role on ETV long-term results. So they are hydrocephalus and etiology, age, and of course third ventricle anatomy. Sometimes we can see more than one in the same patient. This box is very representative, showing in details each aspect of the main factors. These red flags represented the main points that affect the overall success rate in the pediatric population. These factors must be considered to indicate an ETV for pediatric patients. Our objective, we analyzed our series, and the aim of this study was to identify the factors that could influence the outcome of ETV in children. So about clinical material and methods, ETV were performed in 148 patients in the same institution for the treatment of hydrocephalus in patients under 18 years old. From 2000 to 27, all procedures were performed by the same surgeon, and success was defined by the following criteria when the further intervention was required to treat hydrocephalus and the absence of signs or symptoms of raised intracranial pressure. Radiological studies during the follow-up were performed in our series when required, according to the patient's clinical assessment. ATV success score was also retrospectively used in our series in order to compare both the predicted and our actual long-term success rate. We divided our series in three different groups according to the age. Group A, under 6 months of age. Group B, between 6 and 12 months of age, and Group C, over than 1 year of age. Statistical analyses were used in order to assess the influence of the following factors on ETV failure: the patient's age at surgery, underlying pathology, birth conditions, and presence or previous shunt, and postoperative complication. We had a female predominance with 85 girls ranging in age from 11 days to 18 years old, with the median age 4.5 years old. The overall success rate for CSF circulation restoration in our series was about 80%. According to the age group, the older the child the better the result, as you can see here in this graph. And for specific etiologies was also statistically significant. Some of the obstructive hydrocephalus as tumor, aqueductal stenosis, and cystic lesions showed the best scores in our series. Prematurity and previous shunt were associated with bad results in long term, as you can see here in these bars, and was statistically significant as factor in bad results. This graph is very interesting, showing the impact of the learning curve. The more selective the indications, the less chance of having complications. So we divided in two periods of our series, and you can see here how decrease the complications when we got better to perform ETV in children. Kaplan-Meier survival was used and showing success rate according to the age group. As you can see here, the best Kaplan-Meier survival was in the group over 1 year of age. And ETV success score was similar and reproductively in our series and was statistically significant, as you can see here also. Some points to be discussed. In most literature series, younger children were not included, and this is very important because it can influence the results and the follow-up. The lower success rate after ETV in younger children may be explained by the poor CSF reabsorption capacity of newborn infants due to immaturity of the arachnoid granulations. Univariate and multivariate analysis showed in our series that both the etiology of hydrocephalus and patient's age group were relevant factors predicting success. This table shows the variables that were statistically significant in our series. So age, birth conditions, previous shunt, etiology, learning curve, as well the ETV success score. A literature review showed that success rate in children under 6 months of age ranged from 32% to 45%, and in children older than 1 year, it ranged from 56% up to 71%. A few studies on literature have been analyzed the postoperative course and success after a period of 3 years. ETV success score has also been proven to be applicable in order to predict long-term outcome. In this series, the overall predicted and actual long-term success rate were clearly correlated, respectively 74 and 79%. And the failure of ETV and previous shunt is also controversial in the literature, as you can see here, two recent papers showing two different results. For Heather et al., they did not find associated with the shunt revision and good results. On the other hand, Volk et al., the German studies, they did not show no significant impact for pre-existing shunt dependence on the long-term success. But in this paper, there were only 31 pediatric cases. In our series, 21 patients had previous shunts, and they underwent ETV, and 7 out of 21 had at least 2 shunt revisions. And in our series, previous shunt was a bad factor. So in conclusion, age and etiology are significant factors and predictors on HIV surgical success in pediatric population. Tumor-related CSF circulation problems and aqueduct stenosis seems to be particularly well suited to ATV regardless of patient's age. Intraventricular hemorrhage, previous CNS infection, myelomeningocele, prematurity, and recurrent shunt revision have been associated with high failure rates on ATV in all age groups, particularly in infants under 6 months of age. Maybe choroidoplex coagulation for young patients is still under critical analysis and could be influence the outcome and after HIV in children. So thank you. On behalf of the Brazilian Society of Pediatric Neurosurgery, I would like to thank you all the participants. On behalf of the Brazilian Society of Pediatric Neurosurgery, I would like to thank you all the participants, delegates, and our sponsor to be here in this neuroendoscopy symposium. My topic today is about endoscopic third ventriculostomy and long-term results in the pediatric population. I have no conflict of interest to declare. Some highlights about ETV in children. So the endoscopic third ventriculostomy management of hydrocephalus in children have reported results that varied widely, ranging from less than 30 up to 100% of success. The medical literature also has extensive and conflict data concerning the whole of patients' age and etiology of hydrocephalus in the success rate of endoscopic procedure. ETV under A2 is also controversial because of high failure rate and technical difficulties. The long-term efficacy of ETV is often under debate, since most studies have reported a rather short